Good morning to one and all, respected chairperson, reverend judges. Dear colleagues and my seniors, my paper will dwell upon a comparative study of various cases managed by plate and screws versus use of indigenous endobuttons for joint reconstruction. Superior results and cost effectiveness have been shown with the endobutton. To begin with, what is an endobutton? Let's jot down a brief history for it. The endobutton is a titanium button-like fixation device which was developed for securely fixing ACL grafts through minimal invasive approaches, also called as arthroscopy. It is placed on either side of the bone tunnels along with graft as shown here, and then flipped or toggled on the outside, creating a strong and stable fixation by holding the graft against the bone. This method helps in avoiding a second incision and eliminating some complications associated with other fixation methods like interference screws. Dear colleagues, as we move on, we'll see other holistic approaches of endobuttons. Now, what are the mechanics? To begin with, an endobutton has various advantages over conventional fastening techniques like screws as staples. It lowers the possibility of graft slippage. Because of the aerodynamics, there is more contact between the graft and the bone tunnel, which aids in stabling and healing. The button-shaped design of the endobutton also helps to better healing outcomes. It decreases stress concentration on the graft by dispersing pressures over a greater area. It allows for proper tensioning of the graft, approximation of fracture segments, especially suitable for longitudinal fractures, addresses diastasis, and reduces the usage of plates and screws. However, it might not be suitable in fractures with rotational issues. Our aims and objectives were pretty simple: to evaluate and assess, compare results using endobutton with other traditional methods of orthopedic devices like suture anchors, orthopedic plates and screws, which was done for acromioclavicular joint injuries, ankle syndesmotic injuries, clinically, radiologically, and functionally. Yes, proper consent was taken from all the patients before surgery. The study period was 1.5 years from June 2024 till December 2025. There were 100 subjects, 84 males and 16 females. The average duration was 12 months. The pre and post surgical American Orthopedic Foot and Ankle Society scores and Constant Murley shoulder scores, together with reported complications and post-operative radiological analysis, were assessed. All males and females between 18 to 60 years were taken in the study. Closed injuries and open wounds of Gustilo-Anderson 3A, which were admitted within 48 hours of the initial insult, were taken. Here we can see one such case where we can see a Gustilo-Anderson 3A. He was also admitted to our hospital following a road traffic accident. Now, patients having immunodeficiency diseases and other comorbidities which could delay healing were excluded. Patients not willing to give consent were also excluded, and Gustilo-Anderson 3B and above were excluded. We can see in this video how the endobutton is threaded so that it is converted into a sliding mechanism to achieve secure non-slipping fixation. This was an indigenous technique where we utilized a polyester braided surgical suture jointly with double mini hole 2 plates, number 2 polygalactin 910 suture, a 4 mm drill bit together with a 15 cm long needle. This was done under image intensifier. And this is how we have devised our own sliding knock technique. Dear colleagues, we can see this is how we can appreciate the self-locking mechanism of endobutton. This itself has resulted in extreme cost reductions. For a surgical technique, it was simple. A 3 cm mini incision was made over the clavicle, medial to the acromioclavicular joint. And a 2 cm incision is made over the coracoid process, and the endobutton is passed through the coracoid process. Some examples. We can see in the first case, there is a diastasis. In the second case, we can see a completely blown out shoulder. Dear colleagues, as we can appreciate, 2 endobuttons sitting flush on the clavicle and on the coracoid process with near exact anatomical reduction of the joint. And this is the radiological view. After 6 months, we can see a satisfactory range of motions at 6 weeks. We can see the full range of motion. The patient is happy. Complete near circumduction in all coronal and axial and sagittal planes can be seen here. One such case of Gustilo-Anderson 3A can be seen here. Again, we can see a satisfyingly improvement in range of motion thanks to our physiotherapy team. For ankle injury diastasis, if one can appreciate, we also have a posterior malleus fracture here, along with a fibula fracture, medial malleus, and syndesmotic injury. For the lower extremity standard, direct lateral medial approaches were used for syndesmosis reconstruction. We can see endobutton coupled here with a plate. We can appreciate even the posterior malleus was fixed with the endobutton instead of using hardware devices. And this is an on-table scintigraphic view. Dear colleagues, we can see we are taking the angle through a huge range of motion, lot of stress till then. We cannot see any widening of the diastasis. Endobutton sits sturdy and perfect. So we used a paired t-test, and we can see the chart simplifies the comparison of cost effectiveness, recovery time and visual analog scale for the 3 surgical techniques based on a 5-point scale. And as evident from the images shown and for the calculations, the p-value was significant. Radiologically, the acromioclavicular joint distance, medial clear space, tibiofibular clear space and the tibiofibular overlap measurement showed a significant improvement. No cases of deep surgical infection, suture failure, knot slippage, perioperative infection or postoperative heterotopic calcification were reported. Yes, there were complications with partial loss of reduction observed in 2 patients. One patient was plate fixation developed a superficial infection. Other patient reported mild shoulder pain at final follow-up, but it did not interfere with daily activities. Coming on to the cost, we can see a clavicle plate cost around 38,000 rupees. For the big boy of orthopedics, we use suturing, that is 55,000. And yeah, as I work in DSP, we can see just 100 rupees per piece for the endobutton. The total implant costs around 500 rupees, GST included. So to conclude, syndesmotic screws provide more rigid fixation, resulting in greater stability against translation and compression, while endobutton fixation offers more flexibility and allows for physiological micromotion. In terms of rotational stability, there is no significant difference between the 2 methods. On the other hand, suture anchors are very costly and not easily affordable by the general Indian population. To conclude, ultimately the endobutton's advantages translate into better patient outcomes. The implant can help patients restore strength. The low risk of complications and re-injury may result in shorter recovery durations, allowing patients to resume their busy lifestyle. So, ladies and gentlemen, endobutton is extremely a better choice, affordable, low cost solution, and with that we come to an end. Thank you.